Welcome to Shining a Light on Rare Forms of Bladder Cancer, a patient insight webinar from the Bladder Cancer Advocacy Network. Beacon would like to thank our sponsors, the Estella Seattle Genetic Partnership, Bristol Myers Squibb, the EMD Serono Pfizer Partnership, Genentech, Janssen Oncology, Merck, and PhotoCure for their support of the Patient Insight webinar series. Bladder cancer is a devastating disease with an estimated more than 80,000 new cases expected to be diagnosed in the United States each year. A small portion of those patients will have unusual or rare types of bladder cancer that make them more challenging for doctors to treat. My name is Stephanie Chisholm, and I'm the Director of Education and Research at Beacon. I'm joined today by a leading bladder cancer expert who also has a great deal of experience treating these rare variants of bladder cancer. The chief of the bladder cancer section of the genitourinary malignancies branch of the National Cancer Institute. We're here tonight with with medical oncologist Dr. Andrea Apollo. Dr. Apollo received her MD from Albert Einstein College of Medicine in New York, and she completed an internal medicine residency at New York Presbyterian Hospital. She followed up with a medical oncology fellowship at Memorial Sloan Kettering Center, and then she joined the medical oncology branch of the National Cancer Institute in charge of the bladder cancer translational program. She holds board certifications for internal medicine and medical oncology. Dr. Apollo has served in national and international committees, including the genitourinary track leader of the Education Program Committee and a member of the Scientific Program Committee of the American Society for Clinical Oncology. She's a member of the Bladder Cancer Program Committee of the Society of Urologic Oncology and is a member of the Beacon Scientific Advisory Board. Dr. Apollo is very interested in identifying molecular alterations in tumors that will serve as targets for individualized treatment strategies. Thank you so much, Dr. Apollo, for joining us today.
Thank you for having me, Stephanie, and it is really a great pleasure for me to really highlight the issues and the ongoing efforts in rare bladder cancers. This is a area that I am very interested in because as a tertiary center here at the NIH, we see a lot of rare tumors and the treatments are limited. So what I'm going to do today is I'm going to talk about what these rare tumors are, what are the efforts ongoing right now, what do we know about them in terms of prognosis, in terms of treatment, in terms of diagnosis, and there's really two groups that I'm going to talk about. I'm going to talk about the pure rares that are not urothelial carcinoma, that make up the other 10% of urothelial carcinomas, that histology, and I'm going to talk about the urothelial carcinoma histologies that are mixed, that have rare components in them, and therefore these tumors behave differently. So next slide.
You should be able to advance the slides. Do you want to try to do that?
I don't have the, okay, did I do that or did you do that?
You did that.
Okay, terrific. So I'll use the arrow. So urothelial carcinoma is the predominant histology for bladder cancers, but there are other histologies such as squamous cell carcinoma, adenocarcinoma, and small cell carcinoma. When we talk about, I'm going to go back just to say something quickly. When we talk about treatments for bladder cancer, we really talk about treatments for urothelial carcinoma. So all the new FDA approvals, all of the clinical trials, these are all patients with urothelial carcinoma. The rare tumors are, they're too uncommon to enroll in clinical trials in a prospective manner or in a randomized manner. There's just not enough patients. So we do lack evidence in terms of the best treatment options for these patients, and that's what I'm going to highlight today. In terms of the presentation for rare bladder tumors, the presentation is similar to urothelial carcinoma tumors in that they present with painless hematuria. This can be gross visible hematuria, blood in the urine, or microscopic, that's picked up by a doctor's office. Also, there can be voiding symptoms, symptoms when you urinate, such as frequency, urgency, or pain with urination. In terms of how it's initially evaluated, it's managed similar to urothelial carcinoma of the bladder in that generally a urologist looks inside the bladder using a cystoscope. And if it's appropriate and they see a tumor, they may do a transurethral resection of the bladder tumor, or something that we call a TURBT. This is both diagnostic and also therapeutic. In more advanced disease, more imaging may be done with a CT of the chest, abdomen, and pelvis, and if mass is found, often a needle biopsy is performed. So we'll start off with squamous cell carcinoma of the bladder, and these account for 5% of the rare tumors seen, the rare bladder cancer tumors. Not advancing with my arrow. I think, Stephanie, you're advancing for me. I don't see an arrow for me to advance. All right, so squamous cell carcinoma accounts for about 1.2 to 5% of bladder carcinomas in the Western countries. It is associated with infection with schistosomiasis, which is endemic in the Nile River Valley in Africa. And cases of bladder cancer are very high in Egypt, and they're associated with this parasite. Here in the United States, this is very rare and not a risk factor. Generally, the predisposing risk factors for squamous cell carcinoma of the bladder are chronic urinary tract infections, patients with spinal cord injury that have indwelling catheters, urinary tract stones, prior pelvic radiation. The median age for squamous cell carcinoma is 68, and similar to urothelial carcinoma, there's a male predominance. So squamous cell carcinoma are often present with advanced stage. These are high grade, and they do have a high rate of muscle invasion. Only about 2.6% of these present as non-muscle invasive disease. About 20% of the time, these patients already have lymph node involvement at presentation, but they do have a lower rate of distant metastases. These tumors tend to spread locally and generally causing issues with local blockage or pain. And when they're treated and they recur, so if the patient had the bladder removed and the cancer comes back, these generally come back locally, not with distant metastases, as urothelial carcinoma can happen with metastases in other organs. This is generally a local spread. Next slide. So for patients with non-muscle invasive disease and squamous cell carcinoma, cystectomy, early cystectomy is advised because these tumors just don't respond to chemotherapy. Radiation is effective and may be appropriate in some patients undergoing surgery, and that can happen either before the surgery, called neoadjuvant radiation, or after the surgery, called adjuvant radiation in certain patients. The systemic therapy with chemotherapy, although it has shown to have some response in terms of shrinking of the tumor, it really hasn't, we haven't seen improvement in survival with chemotherapy, so it may be good for symptom control. And we use regimens similar to those used for urothelial carcinoma. These include gemcitabine and cisplatin. Another regimen that has been tested in rare tumors is ITP, and that stands for ifosfamide, paclitaxel, and cisplatin. That's a combination of chemotherapy, and both these regimens show about 24% response in the first-line setting. Next slide.